Welcome to the Egg Whisperer Show. I'm Dr. Amy, and I'm here to help you stay informed and hopeful on your path to parenthood. Today, we're talking about age, weight, unexplained infertility, and how these factors shape real decisions for people trying to get pregnant. I'm so excited to have one of my former mentors and professors, Dr. Penzias, on to discuss how your age and weight factor into the fertility equation. He's medical director at Boston IVF and associate professor at Harvard Medical School. He recently published an editorial in the Annals of Internal Medicine titled The Weighty Issue of Obesity and Reproductive Success. It highlights how age and weight influence fertility, why unexplained infertility remains one of the most challenging categories, and how IVF fits into the picture. Dr. Penzias, what first led you into reproductive endocrinology and the incredible work that you do today?
Well, Dr. Amy, thank you so much for having me today. It's a real pleasure and honor for me. My origin story is pretty simple. I was doing an elective between my first and second year of medical school and working with a reproductive endocrinologist. She was terrific, but we didn't have an IVF program like most medical schools didn't at that time. But the field of IVF was new and exciting. It was really disruptive technology that was poised to help millions of people who otherwise could never have been able to become pregnant. And I saw this as an opportunity for me not only to help patients directly, but also get involved in a field where I could do research to help those beyond who I would treat personally.
I can only imagine the number of families that you've helped and the number of students that you've mentored, the research that you've done. It's an incredible career. So let's talk about your paper, The Weighty Issue of Obesity and Reproductive Success. Your paper points out that infertility affects about 17.5% of people worldwide. Why is it important to patients understand this broader context when starting their own journey?
Great question. When we think about that, 17.5% is a little bit more than 1 in 6 people. And it's not a cause for panic, but it's really a call for information. I think that the idea that being aware that there is a problem, potentially, even before you start, take that into your planning.
Yeah, that's a great point. And in your article, you also note that age remains the strongest predictor of fertility. And in my practice here in the Bay Area, and I'm sure you're seeing that in Boston as well, patients are waiting longer. How should patients think about age when deciding how quickly to move forward with treatment? And do you recommend this for both men and women?
Age is certainly the strongest predictor of success in becoming pregnant, and particularly a woman's age. A man's age does have some influence, a little bit less directly overall, but we encourage both to be thinking about it. We know that the fertility decline is a silent thing overall, and that's, I think, one of the hallmarks. You can't tell if your fertility is going away. And so the idea that knowledge is power, being able to take into account what your age is, being able to take into account if things aren't working properly, then go to see a medical provider sooner than later.
Yeah. And the average age of my patient each month, it's anywhere from 40 to 42. And I know many patients are advised to go to IVF first, and many also want to try other methods. What have you seen that works for people of advanced maternal age? I don't like the word advanced maternal age because I feel like it makes women feel old as moms. And I'm the age I'm at, I don't certainly feel old. So I'm never going to call one of my patients old. So I like to use the word advanced mitochondrial age. How should patients think about it as far as how quickly to move into treatment?
The idea of using sort of descriptors of age comes with it some negative pejorative things that may make people feel shame. And we never want to do that. We want people to feel empowered. We want people to feel and be their healthiest self. I think that one of the bigger drivers when people reach the age of 40 or more is how many children they would like to have ideally. Because I think that really is part of the equation that fertility that factors into how quickly to seek fertility care, what kind of treatment is available, and what to really action in your big picture game planning. From a treatment standpoint, I know that there are, over the years, have been many, many different supplements that people talk about. There are fads and trends in our field that have been around for a very long time. Some are flash in the pan, some go away quickly, some stick around a little bit longer. But I think being the healthiest you is really the best way to start.
I couldn't agree more. I do all these little dances for my patients. Well, I guess in my head, I'm dancing. I do things like believe, make sure you're not depressed or anxious, sleep, eat healthy, do strength training, make sure that you're emotionally feeling well, move your legs. And those things are just good for just lifelong health. And I consider us fertility fortune tellers, right? Like we can forecast for patients. We're not going to be perfect about it because certainly I have patients where I say your chances are low, and then they get pregnant at an age where I would have never thought. I have two patients now pregnant with their own eggs at 47. And do you know what I did
Yeah,
to help them?
tell me.
Absolutely nothing. I did nothing. I did nothing to help them. And they're like, Dr. Amy, I got pregnant. And I'm like, oh my God, that is so wild because now I can just share with people it can happen, but that's two patients in a career of over 20 years.
And I think that your point is exactly correct because it's individuals who get pregnant. And those are the ones, as people get older, those kind of stories become more and more remarkable. Just the fact that you're telling me about these two 47-year-olds, I think it would be less common for you to say, hey, would you guess what? I had two 27-year-olds who got pregnant. So, really, what we're thinking about is for any individual at any age, it's the last egg you ovulate is your last chance of becoming pregnant. It's a question of relative to you and 100 others in your situation, how many are likely to become pregnant without medical assistance? How many are likely to become pregnant with medical assistance? And those are the things that we, as fertility doctors, as you well know, have to balance in terms of our counseling.
So, you explore how weight impacts reproductive success in your paper. For those trying to conceive, what are the most important takeaways from the research on obesity and fertility? And before you answer that, is there a nicer word for obesity? I don't know why obesity just seems like a bad word. And I use the word curvy if someone's a little on the curvier side. But anyways,
Yeah, I think that the terms that we use are very medical, and sometimes they have some pejorative negatives that are associated with them, and really lead to shame. Talking to somebody and saying, "Well, you're a little overweight," you know you're a little bit overweight, but also once you mention that they're obese because they happen to fit a specific body mass index category that the National Institutes of Health came up with, all of a sudden induces incredible shame, makes people withdraw and feel bad about themselves. And that's really not the point. The way that I typically phrase it is talking about body mass index, BMI, which is a relative index that's a calculated formula. And I talk about the impact of somebody's BMI on their likelihood of pregnancy. And it's a sliding scale. It's actually a U shaped curve, meaning at the lower end, there is a point at which you get too low a BMI, you're going to decrease your chance of pregnancy. And at the upper end, the higher it goes, you're going to decrease your chance of pregnancy. So it's really trying to help people find that optimization point relative to their body mass index. And I think that that doesn't have so many negatives associated with it.
right, absolutely. And if you tell patients you're not trying to hurt their feelings when you're talking about their body size, I think that helps. And I see patients who've seen five, six doctors before seeing me, and they're like, Amy, you're the first doctor who's ever brought it up. I thought it was probably a big deal, but since no one brought it up, I didn't think that it could influence my fertility. So, what are the most important takeaways from the research on obesity and fertility?
Yeah, the most important takeaways that we know from historical data, and I had been the chair of the practice committee for the American Society for Reproductive Medicine for 6 years. And during my tenure as chair, we produced an article about overweight and the impact of fertility and the outcomes of different treatments and the outcomes of people trying to get pregnant without medical assistance. And there are some very nice charts that are publicly available that show the relative increase in body mass index and the associated decline in the likelihood of success, either naturally or also with fertility treatment. There also seems to be a little bit of an increase in the risk of miscarriage as the body mass index rises. So, those are the kinds of things that are helpful to focus on. And I hear what you're saying about doctors feeling uncomfortable and not bringing this up enough. And I think that we, like fertility, has been something that fortunately many people can now talk about. There used to be shame and people didn't even talk about it. I think we have to bring weight into the equation to help our patients.
You also highlight that weight loss sometimes improves the chances of natural conception. How do you guide patients in balancing the time needed for weight changes with the age related fertility decline? Because I got to tell you, when I tell someone, maybe let's take 2 or 3 months off, and we'll talk more about some of the therapies that are out there. And they just feel like there's a ticking clock and they have egg panic and they just feel anxious about it. How do you frame that conversation with them?
It really a lot depends on the age that somebody is and how much impact we think we can achieve. Because if we think about the difference in the odds of pregnancy over a 2 year window, so somebody who's currently 34 and is going to try to get pregnant at 36, the difference in those two ages is fairly narrow. It's a little bit of a decline, but not massive. The difference between somebody who is 42 and 44 is much, much bigger. So, my conversation about weight loss and the impact of weight loss is going to be different for those two individuals, given the fact that there may need to be some time to lose weight. The other thing is, I think that many times when patients have come to me and talked about unsuccessful attempts at weight loss, sometimes it's because the doctor just says you need to lose weight. There's no target, there's no end point. What I also like to do is I like to look at a patient's current body mass index and tell them that if we take a look at trying to get some marginal degree of improvement, if we can improve that by reducing their BMI by 2 points on that scale, that they may be able to achieve a 10 or 15 or 20% increase in the likelihood of pregnancy. Now, if that person is fairly young and is game to try, we may do so before we even do any kind of fertility procedures because they have the time potentially to be able to do that. If somebody's on the older side, what we may end up doing is doing in vitro fertilization now, capture the eggs at their current age, and then engage in a strategy of weight loss so that the embryos can go back into the patient at a lower body mass index.
Yeah. And does your center have a BMI cutoff for patients who can undergo an egg retrieval?
Because we're an outpatient freestanding surgery center, we are unable to safely offer anesthesia to anyone with a body mass index above 45. So I have a patient that I saw this week who has a body mass index of 51. And at our initial visit, about a month and a half ago, we talked about that right out in the open. So one of the things to do is I immediately engaged on this very important aspect of her care and talked about exactly how much weight it would take to get from her BMI currently of 51 down to 45. And given her age, how we might approach this as part of a comprehensive plan. And if all else failed, what we would do thereafter.
Thank you for sharing. I'll share ours. Ours is actually 38. It's 38 because we don't want them to be at 40 by the time they get to retrieval. So that's what our anesthesiologists prefer here. But it's really important for someone to know what that is at your center so that you're not making plans for a cycle and then find out you can't start when you wanted to, because that can be incredibly disappointing.
That's a great point about the BMI because I think that many times patients may have the misperception that we don't want to take care of them. We don't want to meet them where they are, and all of us do. But I think that your point is, and what all of the surgery centers around the country are doing is developing safety protocols because while we all want to help people, we would never want somebody to end up with an anesthetic complication that could be very, very serious and even life threatening because in our center, we're unable to handle somebody with a body mass index that exceeds a certain threshold.
Right, right. And your paper also touches on unexplained infertility, which affects up to 30% of patients. And we know that there are often explanations, but they're just not explained enough. And I know you've gone into in depth discussing unexplained before in your YouTube video, evidence based approach to unexplained infertility. What is the overlap here across age and weight in your most recent article?
When we do the fertility evaluation, many times it tells us what the problem isn't more than what it is. If we do a uterine imaging and fallopian tube imaging study, a hysterosalpingogram, and the tubes are open and the uterine cavity looks normal, we tell them, oh, the problem that you're experiencing is not because you have a blocked tubes or a blocked uterus, but it doesn't tell us what the cause is. And so on and so forth down the line of tests that we do. So we know that there are variables that are very impactful on outcome, and things such as weight can be one of them. So, in the category of unexplained, there may be a degree of influence that the weight is having on a problem that we may not have a test to correctly identify.
Yeah, so that's so true. That's my approach as well. I always start my new patient calls with, this is what we know. These are the tests you have. This is what we can already tell about you, and this is what we don't know. So thank you for saying that. You mentioned that some fertility challenges are not solved by weight changes. Can you talk about the conditions where medical intervention is essential from the start?
Absolutely. And this is why that when anybody is having a problem, they should get a comprehensive evaluation immediately. And that includes if they're in a partnered relationship, a heterosexual partnership, the man should be tested as well as the woman in the relationship. And the reason is male factor infertility is something that is relatively easily diagnosed. And a normal semen ejaculate volume does not mean that there are any sperm cells in there. And that's something that can't be fixed with weight loss. Other conditions, such as pelvic adhesive disease, that is the result either of previous infection, known or unknown, or a very serious condition that's incredibly widespread, endometriosis. Those are the kinds of things that no degree of weight loss can overcome, and good fertility therapies are available to address.
Yeah, great points. So I want to talk a little bit about some of the interventions. What should patients consider as a weight loss option? And I'd love to hear your thoughts on GLP-1s.
The GLP-1s have been a game changer in medicine. We've seen tremendous health benefits in the reduction of risk from comorbidities like diabetes, hypertension, cardiovascular disease. So we know that this is having a massive impact in a positive way on the overall health of the people who are taking these medications. We know that the health and safety data for people being pregnant and being on them is just not there at this point. So there may be a good use of a short-term strategy with a targeted amount of weight loss planned and using a GLP-1 agonist in order to help get that weight loss going in a very effective manner, hit that target, move on to the treatment you need after a brief washout interval, and then resume other lifestyle changes.
Yeah, I probably have about 20% of my patients on tirzepatide. I talk to my patients about it, talk to them about the side effects, remind them not to drink alcohol because half a glass of wine can feel like a bottle. So, very important to know that. I also have a fertility weight loss doctor. That's her specialty. Her name is Dr. Stephanie Fine. She's amazing. And for patients who don't like, you don't have to take medications to achieve your goals, but oftentimes patients have done everything, all the diets, all they've met with nutritionists and they just haven't been able to do it. So the GLP-1 is such a great assistant for our patients. What other weight loss options do you discuss with your patients?
We have a nutritionist on staff, Hillary Wright, who we refer patients to help them with their diet because, as you point out, many people have tried everything, and to be able to come up with a good specific plan for them, it's something more helpful to have it customized and bespoke rather than just reading it out of a book or seeking out online or something like that. The other thing that we do is we have partnered with a commercial entity that has an online presence where there's access to a nutritionist and a medical endocrinologist who can actually prescribe not only the GLP-1 agonists, but other medications if need be, and help manage some of the potential side effects of them, but also craft a plan that is meshed nicely with our fertility goals.
Awesome. I have these sayings that I tell patients, like I tell them pregnancy requires more energy than like 9 marathons. So train as if you're training for a marathon when you're thinking about getting pregnant. And I have this 10-minute mile rule. You should feel like you can effortlessly run a 10-minute mile. And if you can't, you're not in shape enough to be pregnant. And people look at me like, I can't run a 10-minute mile right now. I'm like, get to work. So, do you have any tips like that you share with patients, lifestyle or health habits that you consistently see make a measurable difference for patients who are preparing to get pregnant?
Absolutely. For me, my comment is every day is a new day. This is not cumulative. So if you felt, and because I think that all of us have observed, somebody will start, they'll have a day or 2 days in a row where they're feeling good. And then they'll have something that is maybe they'll have a little ice cream or a little celebration or drink a little too much. And they feel like they've broken their momentum and that everything is lost and they can never do this. But it's one step at a time. And my philosophy is do the as if. And what is the as if? That is, think about going to the gym and then go to the gym as if you really wanted to. And if you get to the gym and you walk down the stairs to the locker room and you decide to say, you know what, I'm going to go home and walk back up the stairs, you've done 2 staircases more than you would have if you hadn't gone. And so everything counts. Every step counts. Every step that you do for the right direction counts. Every choice you make counts. And give yourself points for the good. Don't worry so much about the bad, but just keep building those points for yourself. Because every time you do a positive for yourself, you're putting your thumb on the scale towards success for the future.
I love that. So, where do you see future research heading in the intersection of age, weight, and unexplained infertility?
I think that with all of the data we have about the impact of advancing age on decreased fertility and the impact of the body mass index, and being able to understand how long it may reasonably take different individuals to become pregnant, I imagine that the research that we are hoping to produce, because of the massive data sets that we have, is to be able to understand and plug into an algorithm a person's age, how many children they wish to have, how long they've been trying to get pregnant, their current weight, and then kind of hit the button and let the formula give us an optimized idea of timeline. So, for example, somebody who comes in and they're 40 or 41 who has to lose 10 pounds in order to hit that target top BMI, we might say, you know what, at that age, we're going to just move forward quickly because the time that it would take to lose those 10 pounds is not worth it relative to the decline in fertility at that age, as opposed to somebody coming in who's 29 who may have to lose 20 pounds. We may decide that in collaboration with our patient and sharing the data, that if she spends a certain amount of time losing weight using a particular recommended protocol and hits that target goal, she may be able to achieve 15, 20, or 30% higher chance of success now and into the future. So that's, I think, the use of the data and the power of the data sizes that we can work with today.
Yeah, that's incredible. I think patients want data. They want to be shown something. And I think as doctors, it's easy for us to say something, right? And just say, you should lose weight because of this. But when you can actually show them something that like they can read and see, I think it kind of sinks in a little bit better.
And I think that because people have so much access to free information, patients can directly access the medical literature with very few barriers. There are some independent websites that are out there that may or may not provide good or well vetted advice. And I'm just going to put those aside for the moment. But I encourage patients who come in with individual papers to kind of understand that this is one study in the context of many different types of patients, and they may or may not fit that model. And that our job as physicians is not only to read that one paper that they're providing me, but also for me and for you, Dr. Amy, to understand the entire literature and the themes in the literature, and then distill using all of our knowledge, distill all of the different points and all of the data that we have to be able to focus on that individual as a patient. And I'm always grateful when people bring papers to me, and I encourage them to be advocates for themselves. And I think that by finding papers on the internet, people doing a little bit of research and understanding a little bit of the information that's out there, and then bringing this stuff to us, we're able to provide them with an evidence-based plan that will give them assurance that it's not just something we're making up off the top of our heads.
So, for listeners who are feeling overwhelmed by these variables, and certainly it is, I mean, it's overwhelming to think that you should take time off to lose weight. What would you encourage them to focus on first?
I would encourage people to focus on a couple of things. very few people decide overnight that they're going to get pregnant. Usually, in my experience, people have a general idea of when they would like to get pregnant. So I think that for the general public, I would say think about your age, think about your current weight, and think about when that time frame that you'd like to get pregnant may be. And start optimizing your health now. Because if you start making very small changes well in advance of your desired goal of when you'd like to become pregnant, you may be able to achieve a target goal by the time you are trying to get pregnant and may not need medical assistance at all, which would be fantastic. But if you do, you'll be in optimal position to allow us to use the tools that we have to the fullest extent and apply them to your success. OBGYNs can be great partners for us, and I would encourage every OBGYN to start having this conversation with their patients very early on. At the first time you're meeting somebody, start asking them, hey, when do you think you might want to get pregnant? How can we help optimize your health so that when you want to have that goal, you're going to achieve it?
Yeah, and it'll make the OBGYN's job a lot easier too. Less complications like gestational diabetes, hypertension, and preterm labor.
I think that all of us need to become more comfortable talking to our patients about weight and the impact that it has on outcomes. I think that we have been afraid of insulting our patients, which none of us want to do. And being able to develop language around body mass index and size and how that may impact their outcomes is being honest and being helpful, and doing so in a way that doesn't induce shame but rather empowers somebody to take control of their health to the extent that they can. I think that that's all very positive and really something we should all aspire to.
Yeah, I agree. The way I ask patients is I always ask them first. I say, I'm going to talk about something that's very personal. I'd like to talk about your body size. I know your husband's right here. Do I have your permission to number one, talk about it and talk about it in your husband's presence? Because I think sometimes that's a really touchy subject, especially when your partner is listening. Because I always tell my husband, I'm always this weight to you.
That is a
How can
great
people,
point. Yeah, that's
yeah.
a great point because you never want to embarrass somebody in front of their partner or make them again. It just makes people fold up and not hear much of the rest of the consult.
Right. So, how can people connect with you and where can they learn more about your work?
They can connect with me and learn more about the research that we're doing through our website, bostonivf.com. And that's probably the best way to find us because we're constantly putting up the new research that we're doing. And there's a contact us page. And if somebody wants to send an email through, it'll get to me.
Excellent. Before we sign off, is there anything else you want to add?
I think that the best thing that we can tell patients is that this is something that we have been very familiar with for a very long time, that there are multiple factors that impact fertility, and that there is amazing help that we can provide. So don't fear coming to see us. In fact, come to us a little sooner than you think you might, and you'll be surprised at what we can do to help.
Yeah, I love that. That's great. So, Dr. Penzias, thank you for sharing your thoughts and your research today. All links to today's conversation will be in the show notes. Be sure to subscribe to the Egg Whisperer Show on YouTube and Spotify. Keep taking steady steps on your journey and keep your spark bright as you move toward your goals.